Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk. I'm here with Professor Mike Grocott and guest Dr. Tim Miller, and we are lucky enough to be joined by Dr. Dan Sessler from the Cleveland Clinic. And Dan very kindly came over to be a plenary lecturer with us in London earlier this year for the Perioperative Medicine Conference. I'm sure you all know Dan as one of the most famous and impactful investigators in the world in perioperative medicine. And more recently, the discussions we've been having with Dan, Dr. Sessler, have been related to an old friend, which is blood pressure. So at the plenary lecture we heard in London, and again reiterated in the lunchtime session that we were both at today where he was speaking, we were hearing that what appeared to be relatively transient episodes of intraoperative hypotension are associated with very significant harm. So Dan, could you just run us over that again? Because I think we're still all a little bit shocked by how little hypotension over such a short period can have such profound effects.
Anesthesiologists have always managed blood pressure, but we never really knew at what level to manage it. And a reasonable question, of course, is why after 160 years of anesthesia we don't know this already. There actually is a good answer, which is that you need big data. This is not something you can do anecdotally, and it's not something you can do in a few hundred patients. You need tens of thousands of accurate minute-by-minute blood pressure recordings to do this sort of analysis. We've now looked at hypotension under a variety of circumstances in the operating room, in ICUs, on surgical wards, and what we find is that moderate levels of hypotension for short periods of time are very strongly associated with myocardial injury, acute kidney injury, and death.
So we heard, again, we're very shocked by it. So as little as 1 minute. Is that right? The association is there for as little as 1 minute.
By the time you get to a mean arterial pressure of 50 millimeters of mercury, 50 millimeters of mercury during surgery, it takes 1 minute to significantly increase risk. Now, understand, this doesn't mean that everybody who gets to 50 has a myocardial infarction or dies. What I'm saying is that it increases risk by a statistically significant amount.
So Tim Miller, were you shocked by that?
I think I appreciated that hypotension caused harm, but was I shocked by the fact that 1 minute caused a statistically significant increase in harm? Yes. Was I also shocked by the fact that a third of these events occurred between induction and incision, so were purely influenced by anesthesia? I think that's the second yes.
So influenced by anesthesia, can we be clear on that? I know it's happening in that window, but Dan, where do we stand on whether or not that is iatrogenic, created by us, or whether it's just a patient abnormality that we have not given enough attention to?
Okay, the distinction is important because sicker patients are more likely to get hypotensive, sicker patients are more likely to have bad outcomes. The hypotension may simply be an indicator of sickness. Fortunately, there was just a study published by Emmanuel Fouté, and this was a randomized trial of intraoperative blood pressure management, and what it shows is that tightly managing blood pressure reduces the risk of a composite of serious complications by 25%. 25% is a lot. That's a big deal. And it indicates that at least a fraction of this association is causally related. And by that I mean that intervening prevents the outcome.
And when I read that paper, I saw that there was a dual intervention, although the primary headline intervention was the infusion of a vasoactive agent to target blood pressure at 10% of zero. When I read the appendices, they appeared to have addressed what bothers me when it comes to treating hypotension. They appeared to make some attempt to address the preload before they started the vasopressor, but it's buried in the appendix, because I still think we're a bit uncertain as to whether we go straight in with the vasopressors or whether it's fluid followed by vasopressors.
volume intervention, that is using guided fluid management to adjust volume, was done in both groups.
Yeah.
So the difference between the groups has nothing to do with the volume management. I'm not saying that volume management is unimportant, of course. Volume management presumably made it easier to manage the blood pressure, but volume management alone was clearly insufficient. They needed to use norepinephrine infusions, and they showed that using a norepinephrine infusion improves the outcome. We also have recent results showing that a phenylephrine infusion, which might be expected to cause some harm, doesn't.
And in that phenylephrine infusion study, do we know how they handled the volume status, or do we know that they just gave the phenylephrine infusion until there was hypotension and then followed with fluid?
That study was done in neurosurgery, and so all the patients presumably had relatively low volumes.
Okay.
They certainly were not using guided fluid management and tanking people up.
So in interpreting this data and it influencing practice at the moment, Mike, you, like Dan, are involved in the design and delivery of very large clinical trials. Is this enough to change practice, or is this laid down a clear question?
So I admire the VTA trial. It looks like a well-conducted study. I guess that on its own, it's a single trial. The magnitude of effect is striking, but therefore a little bit worthy of concern in such a relatively small number of patients. And I'm also struck by the fact that I think the mechanism that we expected to be in place, certainly from your very big observational data sets, would be all around myocardial injury. And yet the outcomes that appear to be in play in the VTA study are much more related to sepsis, so pneumonia, wound infection, for example. So it's not entirely clear to me how that fits together.
Well, actually, it was almost completely driven by acute kidney injury and consciousness changes.
So conscious, but also there's some significant infection differences there as well for pneumonia and wound infection, I think.
I don't remember, but certainly the bulk of the outcomes, what was driving the composite, what made it significant overall, was acute kidney injury and consciousness changes, presumably delirium.
But I think what we're all agreeing, the mystery, the third man, to quote something from Paul Miles recently that we were missing, is the MINS, is the myocardial injury.
Absolutely. That trial with 300 patients who were all high-risk patients had only one myocardial infarction. That's at least 20 times less than you would expect in this population. That's a mystery. And the study is also small. Yeah. So 300 patients, it's a big study. It's a lot of work to do these. So this is a huge effort. This is not to take anything away from Foutier's effort, but you get fragile results from relatively small studies. Small studies tend to overestimate treatment effect. They don't have myocardial infarctions. The difference in blood pressure was only 6 millimeters of mercury. So there are many reasons to be excited about this trial. It's a huge advance over just having observational data, but it is also obvious that we need a study with thousands of patients that provides really robust outcomes.
So we're now duty-bound to pursue that. And in the interim, these trials are going to take a long time until they get here. Many of us have reflected on the fact that we would have traditionally treated blood pressure, but maybe over the years have become a little bit more lax in how and when we treat blood pressure. Is it reasonable in between to pay more attention to the blood pressure number while we await the big trials?
Personally, I think so. Absolutely. The question is, where is the preponderance of harm? What's likely to happen? The observational data now in many contexts with many different outcomes suggests that short durations of relatively mild hypotension are strongly associated with adverse outcomes. And intraoperatively, harm starts at 65 millimeters of mercury. Gosh, folks, we used to take people to 65 millimeters of mercury intentionally with deliberate hypotension, essentially for surgical convenience. That was probably not the right thing to do. Now, granted, it will be years before we have a large RCT with thousands of people. But in the meantime, you have to take care of tomorrow's patient. What's the preponderance of evidence? The preponderance of evidence is that you should avoid hypotension. It's relatively easy for us to do. We know how to do it. The risk of doing that is relatively small. The risk of allowing hypotension might be really substantial.
So now for the last little bit, I want to concentrate on two windows where we may not necessarily have been as good at measuring blood pressure. And I think we'd all recognise in the way that anaesthesia is provided, there is often a lull after induction of anaesthesia to when knife goes to skin. Now, once knife has gone to skin, we're probably more attentive to what's happening. But there's a window there, and then there's the big known unknown, which is the post-operative, the what happens when the patient leaves the PACU, goes back to the floor, etc. So if we could take, the first one is that bit you referred to earlier, Tim, that gap between induction of anaesthesia and knife to skin. You're telling us, I think, that there is a sign that there's a lot of the harm may happen in that window.
At the Cleveland Clinic, 1/3 of all the hypotension that we observed in non-cardiac surgical patients occurred between induction of anesthesia and skin incision. You can't blame the surgeons for this. It's clearly our fault. It's obviously a response to anesthetic drugs. And it comes from slamming in a high dose of propofol, and then you get hypotension. Everybody recognizes that you get hypotension, but you have this feedback loop where everybody gets hypotension. Everyone says, okay, it'll come up with skin incision, and your patient's alive when you get to recovery, and you begin to think that this is normal and it's okay. But we see that hypotension between induction and incision is as associated with myocardial injury and acute kidney injury as hypotension afterwards. There's no excuse for it.
So, I mean, another way, so that sounds as though that is potentially iatrogenic hemodynamic instability.
Yes, and it's preventable.
Okay, Tim.
I completely agree with Dan, and I think this work is potentially a huge advance. I mean, there definitely was a school of thought that hypotension from sepsis is harmful, but hypotension from induction of anesthesia is an offloaded heart, and it doesn't have the same harm. So therefore, we were all tolerated it, thinking we had good flow and a bit of mild hypotension in that setting would not cause harm. And I think the data that Dan has produced has now gone against that theory. So at our hospital, we have changed practice. We are much more attentive to avoiding mean arterial blood pressure less than 65 throughout the intraoperative journey, and I think post-operatively as well. It doesn't seem to matter the reason for the hypotension. It does seem, from the data that we currently have, that a mean arterial blood pressure less than 65 is associated with harm. And our POCI guidelines that Dan chaired are going to recommend that we avoid a mean arterial blood pressure less than 65.
So pay more attention in that window. I think that's a very easy take-home message. I think that's important to all of us. Now, the big unknown to many of us, what happens next? What happens when that patient goes back to the floor, to the ward? Do we know any more about that?
Okay, surgical wards have been a concern of mine for a long time. We take care of patients exquisitely carefully in the operating room. Then they go to a post-anesthesia care unit where they essentially get ICU care for an hour or so. And then they go up to surgical wards, and it's like the Wild West out there. They get vital signs every 4 hours if they're lucky. Very often it's a nurse who just writes down a number, even if it's quite abnormal, and nobody does anything about it. Heart attacks occur postoperatively. They do not occur intraoperatively. And so I've been very worried about postoperative hypotension. We didn't have good data until recently, but we just now have some data. We have 200 patients with continuous non-invasive blood pressure monitoring for 48 hours after surgery. And what we see is that hypotension is common, profound, and prolonged. lots of patients who had non-cardiac surgery go to surgical wards and they get hypotensive. They get quite hypotensive and they stay that way for a long time. Take for an example, about 10% of patients have 15 continuous minutes with a mean arterial pressure below 65 millimeters of mercury. That's a low pressure even in the operating room, and postoperatively I'm quite sure people need a higher pressure. The nurses missed half of these episodes.
And that is, the Cleveland Clinic is, we think, an extremely good place, well-resourced place, etc. So goodness only knows what it's like in our sorts of places. Mike, do you have any feel or data on that? You look after a lot of post-op patients. Do you think the ward is just unknown?
So I don't have data from our institution, but I find what you're saying entirely credible. I mean, from experience, we do come across patients where the nurses who, certainly in our context, are overpressed. They're looking after a large number of patients, and we have patients who it would not be a surprise if they've been hypertensive for quite a long period of time, but they've had measurement maybe every 4 hours.
And we're not. No one's blaming the nurses or anything here. That the paradigm that we live in is the Q4 blood pressure once they look okay post-operatively. Tim, any data from Duke? What goes on there? Is this a known unknown?
Yeah, no data, but I entirely support what Dan says. I think that it is an unknown. We need to investigate it more, and I think ultimately we probably need more intensive post-operative monitoring for a lot of our patients than we currently have.
So Dan, last couple of minutes, what next? What are we going to do about this?
Okay, well, it's not just hypotension, it's also hypoxemia. Okay. Hypoxemia on surgical wards is also common, profound, and prolonged, and the nurses miss 90% of serious episodes. The only way we're going to solve this is with continuous ward monitoring. And 10 years ago, this would have been impractical and impossible and too expensive, but that's not true anymore. There are now battery-powered wireless devices you can put on patients. You can get blood pressure continuously. And the values need to go into a smart system. I'm not saying that somebody has to sit there and watch every one, but a smart system can identify the one patient in 10 who's getting in trouble. Somebody can look at that, alert things. In the previous generation, we were concerned about failure to rescue. But that's the wrong paradigm for the future. The future has to be preventing crashes. We don't need to wait until people crash and then try to rescue them. We can prevent the crashes.
So do you think for that, do you think that we need the evidence, if you sort of mean, to get on and do what sounds like the right thing, or do you think we're just duty-bound to get on and do what sounds like the right thing?
No, we absolutely need the evidence. We desperately need a large randomized trial of blinded versus unblinded continuous ward monitoring. And it will not change. Hospitals will not adopt this. Nobody will pay for this until there's evidence. But if you have a large randomized trial and you show that continuous monitoring saves lives, then there's no excuse.
And we should get on with it?
We should absolutely get on with it.
Right, well, thank you very much, Dan Sessler, Tim Miller, Mike Grocott. Thank you very much indeed. It's been really wonderful to have you here, Dan, for being so generous with your time. We hope the world is listening. And thanks for all the great work that you're doing.
Thanks for downloading and listening to TopMedTalk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the TopMedTalk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look